Hello, everyone. I'm Dr. Carmen Puliafito, and today I have with me Dr. Sunir Garg, who is Vice Chair of Retina Research at the Wills Eye Hospital and Professor of Ophthalmology at the Stanley Kimmel Medical College of Thomas Jefferson University. Dr. Garg, welcome to Retina Synthesis.
Thanks for having me.
Today, we're going to talk about the QUASAR study of 8 milligram aflibercept for vein occlusion, and then talk about Dr. Garg's strategy in managing all kinds of vein occlusions. Tell us about the QUASAR study.
So the QUASAR study was the phase 3 study that looked at aflibercept 8 milligram for the treatment of retinal vein occlusion. And we included patients who had CRVOs, BRVOs, and HRVOs and randomized them into one of three groups, either aflibercept 2 milligrams given every month for the duration of the study. We'll call that 2Q4. And then two different aflibercept 8 milligram groups, one of which was given for 3 monthly loading doses and then every 8 weeks. We'll call that 8Q3, and another group, which was 8 milligrams given for 5 monthly loading doses before they were extended out to every 8 weeks. We'll call that 8Q5. The primary endpoint was week 36. There's an extension study going on in which we're looking at the same cohort of patients, but they're able to be extended or their interval can be decreased depending on certain activity parameters.
That's great. So, what were the results?
So the results were, as you might expect, which is aflibercept works great for all types of vein occlusions. About half the patients had a BRVO, with the other group being mostly CRVO, but some HRVO in the mixed. Patients had sustained rapid improvement in visual acuity, maintained it out to the primary endpoint. There was a substantial and dramatic decrease in central retinal thickness, which was also maintained out to the study endpoint. But what we found was that patients in the 8 milligram group were able to achieve those results with 2 to 3 fewer injections during a really short study period. And that gives us a really good sense that, look, we can get you great results with a drug that heretofore seems to be as safe as aflibercept 2 milligrams, but potentially be able to bring you in the office less often. The other thing that we looked at was whether baseline CRT seemed to impact best corrected visual acuity or final CRT, and it didn't. So whether you came in with a lot of edema or a ton of edema, you seem to do equally well with any of these three dosing regimens, but you were able to achieve that with fewer injections in the 8 milligram group.
So, all the 8 milligram eyes were treated every 8 weeks. Is that correct?
So they had their initial monthly loading dose, and then they were extended out to 8 weeks. And then starting at around, week 32 to week 40, just depending which group you're in, the plan is then to start extending these patients out by a month at a time to see if we can maintain these gains with even fewer injections as time goes on. And I'm sure we'll see those results this upcoming year.
What what's your own clinical real world experience with extension?
So I've been having good results with it. I'm happy to see that the label for aflibercept 8 milligram has broadened now to include vein occlusions, as well as to enable us to do more frequent dosing for some patients. One of the really interesting things about this study is when you looked at patients at the study end, about 25% of patients in the aflibercept 2 milligram group were stuck on monthly injections. But if you look at the patients with 8 milligrams, only 6% of patients were stuck on monthly injections. And so even with changes in study design, it seems like something is going on where patients, when they're receiving 8 milligrams, have a much higher chance of being able to be extended out to at least 8 weeks rather than being stuck in the office every month. And I think that's very important. And I'm seeing that in my own clinical practice. I'm not as aggressive at spacing patients out as we were in the study. So in the study, the plan is to space people out by monthly intervals. I'm sending them out by 2 weeks at a time, but I'm having really encouraging results so far.
So the treatment horizon for branch vein occlusion and central vein occlusion are different. Is that a correct statement?
Yeah, I mean, they're different diseases. They have different VEGF load. There's different levels of ischemia. Patient outcomes are different between the two. So when you kind of group everybody together, you kind of get this mean visual acuity. But we did a subgroup analysis where we split off BRVOs from the HRVO, CRVO subgroup, and we saw very similar results. Visual acuity got better, CRT got better, fewer injections. So that was very similar. But as you would anticipate, mean final visual acuity was better in the BRVO group.
Yes. In the real world, how long does the average patient with BRVO need to be treated with anti-VEGF?
So that's a question that we get, of course, all the time. And, it's a while. I mean, all these studies that we have are, 6 months, a year, maybe 2 years if you're lucky. But for a lot of patients, they're going to be getting treatments periodically for a few years, is what I tell them. Some people are lucky and get off the train after a couple of years, but I have some patients who need to get treated for, a handful of years or more, just depending on what their particular body is doing. And so I'll tell patients it's a lot of work in the beginning, it's less work as time goes on, but we tailor the treatment frequency to what their eye and what their body needs.
So what about central vein occlusion? What's the forecast there for treatment?
Yeah, so I'll tell them kind of something similar. Like this is tends to be a worse disease rather than being a small branch of the vein. It's the whole vein that's clogged. The oxygen supply is not as good. The nutrient supply is not as good. So your retina's had damage because of that. And unfortunately, I can't unclog the vessel in either condition. So, I tell them I'm basically the guy with a mop and a bucket trying to just clean up all the blood and the plasma, stop that water damage. But I'm really relying on their body to not unclog the vessel, because it doesn't really seem like we can do that, but perhaps to create a bypass around the clog. And, like any construction job, it can take longer and cost more than you'd think. And so, I'm saying, we'll just take it as it comes, but you're probably going to get to know me better than you would want, but not forever. It's not like they're friends with macular degeneration, for example.
So do you initiate treatment on the first visit?
Yeah, so for most patients, I do. If they have symptomatic vein occlusion with meaningful edema, I will not hesitate to treat. I have some patients who have a tiny bit of edema from a branch retinal vein occlusion and they're minimally symptomatic and still 20, 20, 25 on the chart. I'll perhaps bring those patients back in 4 to 6 weeks and check them again, asking them to call me if they notice change on cover. So it's not a one size fits all, but the substantial majority of patients I'm treating the first time I see them.
What's your medical management of both BRVO, CRVO, and HVO patients?
So I'm primarily an anti-VEGF person first, and I'll do their injections monthly. I don't have a specific recipe. So in contrast to the QUASAR study, where patients were injected, you know, with 8 mg for 3 monthly loading doses or 5 monthly loading doses, I'm not that hard and fast. Where my goal is to get them dry, and once I get them dry or their CRT to be back in a normal range, ideally, I'll then start to extend them out slowly at first, but with bigger steps as I go along. And I try to go with an on-label drug. I'm using Aflibercept 8 mg more, but that's newer for me for this indication just because I didn't have approval until very recently for it.
What about neovascular glaucoma these days?
Yes, so it's a thing and something that we need to remain vigilant for. One of the things that we know is although we're great at drying up the edema, obviously we're not able to cure the ischemia. And when patients with a CRVO, for example, or even BRVO, once you stop treatment because they don't need the edema anymore, I'll still follow these patients periodically, whether it's 3 times a year, twice a year, for a while, maybe getting a fluorescein every 12 to 18 months initially, just to make sure that they're not sprouting neovascularization once I stop the VEGF. I'll have a low threshold for adding PRP if I see neovascularization, but I don't do PRP prophylactically in these patients.
So in the 36 weeks of the QUASAR study, did any eyes develop iris neovascularization?
It's a great question. From what I recall, I don't believe so. But you have to remember, at least in the first 36 weeks, patients were treated very frequently with the
Yes.
aflibercept regardless. So, that would probably mask any response. I'll be interested to see what happens as we get patients extended out further, whether we see some of that or not.
When a new patient with vein occlusion comes in to see you, what kind of diagnostic testing do you do?
Usually it's just a clinical exam and an OCT. I don't typically get a fluorescein angiogram. I'll look at the anterior segment. I tend not to gonio everybody unless I'm suspicious that there might be some anterior segment neovascularization. And I'll get a fluorescein if I'm concerned about neovascularization, but typically I don't get one routinely.
What about blood tests? CBC?
I don't. And so, if you're your typical 72-year-old person with hypertension who comes in with a vein occlusion, usually that's the extent of my workup. If you're a younger individual, if you're on oral contraceptives, if there's something that's a little bit atypical, I'll ask if they've had other, thromboses in the past. So that may give me a more targeted workup, but as a matter of routine, I haven't found it to be very useful.
What's the incidence of bilateral central vein occlusion these days?
That is a great question to which I do not have a specific number for you. Very uncommon, at least clinically. There's a few patients over my 2 decades in practice that I recall treating both eyes for vein occlusion, but I don't have a specific number, unfortunately.
Well, anything else we'd like to talk about in terms of vein occlusion these days?
I think there's still a lot that we have to learn, both about, why patients get it and why some patients seem to get off the train earlier rather than later, as you were suggesting. But it's great to have different options available for patients because, as you suggested, it is a number of years worth of treatment. If we can keep people seeing well and keep them out of the office, I think we're really doing them a great service.
What about differences between anti-VEGF agents, bevacizumab, ranibizumab, aflibercept, Vabysmo? Are there differences that matter?
Yeah, I mean, luckily, that's not a loaded question at all. And it's not like our community hasn't spent hundreds and hundreds of hours and millions of dollars trying to tease it out. There's clinically, I think there is an advantage to the on-label drugs. There's we're fortunate that all of our drugs work well for a large number of patients. And that's been shown in numerous studies, both industry sponsored as well as NEI sponsored studies. And we're fortunate that we have them available. Um, all the studies we have thus far suggest that the on-label treatments aren't going to be worse and potentially are better. And even when you look at this QUASAR study, if you just look at the 2 mg versus the 8 mg group, there was a meaningfully higher chance of you being able to be treated less frequently with 8 mg. And these are patients who are getting injected quite frequently. And, if you have a 75% less likely chance of needing to come in monthly with a Aflibercept 8 mg versus 2 mg, there's a value there. And so that tells me that these drugs are different amongst each other. They're not the same. And it's great that we have options for patients, and I will try them on drug number one. And if that gets me the result that I'm anticipating or hoping for, great. But if not, I will move on to drug number two or drug number three or drug number five or add a steroid into the mix because it is a dynamic field and it's not a one size fits all.
What about faricimab?
Yeah, so I use faricimab as well, and we've been having great results with that. I don't know that I have head-to-head data to compare the various drugs because aflibercept 8 mg and faricimab are, of course, newer. And so, we have the phase 3 studies, we have anecdotal reports, we have switch studies, of which there are a number of them pointing you in every direction that you want to look at. And so I'll use all the drugs and I'm pretty much agnostic. The only thing that I want is my patients to do well. And however I might be able to get them there, I'm happy to pursue it.
Well, thanks a lot for a wonderful discussion of this important topic, Sunir.
Thank you. It's always great spending time with you. And I learned a lot from you over the years and continue to do so. Thanks. So thanks, Carmen. I
Thank
appreciate
you.
the invitation.